All right, so we'll just pick up from where we left off last week. And we got down to magnetic susceptibility. So we talked about 5 or 6 artifacts. And I described how the chart is laid out. But we first talked about phase mismapping, also called ghosting, also called motion artifact. So for the test, make sure you know all the different names associated with this artifact. So if you have a matching problem, make sure you know phase mismapping is also called ghosting. Another big column you need to know is the axis which the artifact runs along for each of these artifacts. So it could be the phase, it could be the phase and frequency, it could be just the frequency, it could also be the slice select or the slice direction. So make sure you know the axis. Make sure you know just a quick definition, one sentence definition of the artifact. And so the main thing over here, which will set you apart from being a decent MR technologist to a excellent MR technologist, are going to be your final column over here. What are your remedies? Yeah, you can notice an artifact, but how can I remedy for it? So we talked about phase mismapping, and we talked about several different examples with respiratory motion, anatomy moving. We talked about flow artifact. Then our second artifact we mentioned was aliasing or wrap. And you have phase and frequency wrap, but remember the system automatically compensates for frequency wrap. So most of the time what you're going to be dealing with is our phase wrap. And that's where our anatomy is undersampled because our field of view is too small, or we're not putting on our oversampling, and it wraps into our image because it has the same phase values. Then we talked about chemical shift, and this is really an artifact caused by the difference in precessional frequencies between fat and water. And we know those precessional frequencies vary depending on the field strength. So at a 1.5 Tesla, fat and water precess at a 220 Hertz difference. At a 3 Tesla, they precess at a 440 Hertz difference. But we talked about how this artifact can appear as this dark band and a white band on certain anatomy where fat and water are at an interface. So we common examples here, and we talked about some remedies. And the major remedy we talked about how to really compensate for it is selecting a receiver bandwidth that's a little bit wider or more broad, so that we can get those fat and water molecules closer together so that that artifact is not as pronounced. And then we moved on to chemical misregistration. And once again, this kind of deals with fat and water and how they precess at different rates. But this artifact we sometimes use to our advantage because we're able to do what we call in and out of phase imaging, where sometimes water and fat are in phase, and then at different times, different TEs are out of phase, and then they're back in phase. So we sometimes use this to our advantage by employing a technique called the Dixon Method, where we have fat-only imaging and water-only imaging. But if you have this out-of-phase artifact, typically it looks like this dark banding around organs where you have fat and water within them. So you can see that around the kidneys, the livers, the muscles. All these tissues typically have this dark outline around those organs. So that's how you can tell that this is a chemical misregistration or out-of-phase signal cancellation artifact. And once again, this is field strength dependent. Then we moved on to truncation. This is where you have a banding artifact at high and low signal interfaces. So we got the example of the sagittal C-spine where you have really bright CSF fluid, really dark spinal cord, and then really bright CSF fluid again. And these bandwidths that we're collecting with our receiver coil typically have a more rounded look to them. And we're trying to put these bandwidths that have a rounded frequency into square pixels. And when that happens, we get something like this, where sometimes we have a high signal in a low signal area. And it'll create this, streak of high signal within that spinal cord. So you can see that is prevalent here in the sagittal C-spine. And this can mimic pathology like a syrinx. And remember, a syrinx is basically fluid that's within the spinal cord that can cause pressure and pain. And that could be associated with a Chiari malformation and just general, the CSF is kind of impeded. So we want to make sure that we're not misdiagnosing this patient with a syrinx when it was just an artifact. So a remedy for this is just to increase our phase encoding matrix and oversample that area, because basically we've undersampled it and we didn't select a phase matrix that was large enough. Another example here is the brain. Here you can see these ripples of high and low signal intensities through the brain. And you can see here, sometimes it's hard to see if you're kind of zoomed out. So you have to kind of zoom in sometimes to see these artifacts. And then that's when you have to determine, is this artifact really disrupting the image quality, or can I kind of just move along with my scanning, especially if you have a patient that is like claustrophobic and in a lot of pain. Sometimes that might be the best image that you get. And then our final artifact that we talked about was magnetic susceptibility. So any type of metal we bring into the room is going to cause our magnetic flux lines to rearrange. And that can cause what we call distortion of our image. And it causes this signal void underneath that image because it causes those spins to rapidly decay. So we get signal void and also distortion of our image because it's bending our magnetic flex lines. So if a material is ferromagnetic versus, let's say, paramagnetic, we know ferromagnetic is more attractive to our static magnetic field, so it's going to create a larger artifact. So if you accidentally bring a patient in with a ferromagnetic aneurysm clip, you might have an artifact that covers the entire brain on your localizer. And then you need to be really worried that, okay, now I have potentially something dangerous within our scanner, and I need to think about how to get that patient out safely. So sometimes the best option is to, not to bring them out quickly, but to actually bring them out slowly so it doesn't rotate or torque that aneurysm clip. And we talked about that in our safety lecture back at the beginning of this class. All right, so we got to about right here. So crosstalk is our next artifact. So here, this is kind of the first time, besides magnetic susceptibility, we don't really have another name for this artifact, so it's just called crosstalk. But the main thing here is not to get it confused with cross-excitation, which sounds familiar, but it is a different artifact. All right, so we've experienced this when we talked about our spine lecture, especially when we were going over our L spine. I talked about ways to be, mindful of this artifact and ways to avoid it. But basically, by definition, this is where spins, hydrogen spins, receive 2 RF pulses from 2 different slices, which completely saturate that spin. So imagine a spin here, and you have 2 intersecting slices just because of the way they're angled. And that spin that's underneath that intersection will receive its, initial 90-degree pulse. But then since there's 2 slices above that spin, it's going to get another 90-degree pulse. And we know if we go complete 180, that's complete saturation, and we get 0 signal from that area. So this usually happens at multi-angled imaging when slices physically intersect. So you can see here, this is a common area, is going to be when we're setting up for our axial, oblique, L-spine images, trying to go through those disc spaces. And we know our L-spine has a very lordotic curve to it, and we know some people have a more lordotic curve, some people are kind of more straight up and down. So when you do that, see how at the back here, those slices start to intersect. So this axis is going to be the slice select because it's basically how you arrange those slices. And the example here, it's basically a band of signal loss where those slices overlap. So here on our L-spine axial image, this is a T2 weighted because CSF is bright. You can see that band right here. It's posterior to the spinal canal. So as an MR technologist, do you think we need to redo this scan or should we let it fly because it's not within the anatomy of interest? What do you think?
I've seen people let it slide. I don't know if it's the right thing to do, but
I think you're right, Marcavia. So, this is one of these judgment calls. And if you have a patient that can't withstand any more imaging, you might hold off on maybe possibly doing another T2 axial till the end. But once again, you're not really in the anatomy of interest. Like if there was a tumor back here on this spinous process and you missed it because of this banding artifact, but what they're looking at on these axials is really kind of in this area. So we are looking at the spinal canal. We're looking at how those nerves kind of leave through those foramen right here. You're looking at the joint spaces, and you're looking at the disc material, see if it's impinging or intruding on that spinal canal. So you're right, Marcavius. It might not need to repeat. But, next time you scan a patient, be more conscious of how you angle these slices so this doesn't happen. So I said usually found posterior and working towards the spinal canal in a lumbar spine, especially in the axial imaging. And it's during a multi-stack acquisition. So multi-stack just meaning you have slices, but then you add stacks so that you get slices through this disc space, this disc space, this disc space, this disc space. So a thing you need to really highlight, there's really no remedy here. It's just, being savvy about it and going, okay, well, there's no remedy, but I just need to make sure I don't overlap my slices. So I need to be careful of how oblique I angle those slices so they don't overlap. And, some technologists, what they do is that L5-S1 joint space is usually the most lordotic in terms of how that disc space is aligned. So sometimes they'll do a stack through 1 through 4, and then they'll just do a separate scan just through that L5-S1 joint space too. So that's another way that you could remedy that. So who have seen that kind of action where, they've maybe done 2 stacks, one up where the L-spine's a little straighter up, and then another one where the L-spine's really curved down below. Any hands seen that one before? Yeah, so Rosemary, Marcavia. So you guys have kind of seen that. So that's the reason behind it. All right, so let's move on down. So do not get it confused with cross-excitation. So this artifact is caused by RF pulses are not exactly square. So we know that they typically have a more rounded appearance. So they kind of have this wavelength kind of look to it. So this is what they look like, the RF pulses, kind of more rounded. So this particular artifact can result in nuclei in nearby slices becoming excited at the improper time. So these neighboring nuclei will become more saturated. We know if it's saturated, partial, or complete, we're going to have a reduction of our signal. And this affects the image contrast, basically how we visualize these tissues. We're not going to really see the difference between the white and gray matter. We're not going to see the difference between the CSF fluid and the brain tissue. So this is our true slice profile. And this is what we would think of like if we wanted to set up our slices where we want slice 1, slice 2, slice 3. But with this being the true slice profile, we get this overlapping of the slices at this point right here. And just like our Crosstalk artifact, if you have a slice overlapping, those particular nuclei are going to receive 2 RF pulses, and they're going to be completely saturated. And that's what's going to cause this cross-excitation artifact. So take a look at these 2 images. So If you have cross-excitation, once again, you get saturation, which causes the contrast, imaging contrast to vary. So look, you can't really see the difference between the white and gray matter on this particular T2 weighted image. And just look at the CSF fluid. It's not as bright as over here because all those slices are starting to overlap and the nuclei are getting saturated. So this is where we have good image contrast, and we'll talk about how we remedied this artifact. So look at the white and gray matter. You can see the difference between those tissues. One's a more darker gray, one's a little brighter. Look at our CSF fluid is really bright compared to over here. So this artifact's going to be apparent in the slice select. So you're not going to see it streak across your image, but as you flip through your slices, you're just going to see this kind of, you know, image that it has poor image quality because it has what we say low image contrast. So what are some remedies? So since our slice profile looks like this, and they are more rounded, and we're going to have a little bit of overlap, our remedy is to basically space these slices out a little bit. And how we do that is by applying a slice gap of at least 30%. So if you're, let's say for example, if your slice was 1 millimeter, what would be 30% of that? .3 millimeters. So good. So if this was a 1 millimeter slice, we would just put 0.3 millimeters in between. Okay. There's also an option on some of the scanners to actually square off the RF pulses. But even when we do that, we want to still leave at least a 0.1% or just a 10% gap or 0.1 gap. So that would be something more like this, where there's 0.1 gap, and we were able to square those off a little bit more. But I think the best way to do it is to select this option called interleaving or concatenation. And I know you guys have kind of experienced that, where you're, you know, maybe your TR is a little bit too long, and the technologists go, well, why don't we bump up our concatenation, or, you know, why don't we bump up, you know, this interleave option? And you're always like, well, I wonder what that really means. And what that really means is basically we go from trying to fill every slice in one TR period, we divide it into 2 TR periods where we fill slice 1, 3, 5, and then we go back in and fill slice 2, 4, 6 in the next TR period. It's going to increase our scan time a little bit, but at the same time, it gives us this built-in gap where we're not scanning slice 1 and then directly slice 2. We're skipping over slice 2 and then going back the next TR period to fill slice 2. So it kind of adds this built-in gap where you don't even need to provide a gap between the slices, which is nice because, once again, if you do have a pathology that happens to be in that 0.3 millimeter gap, which is very rare because that's a very fine or very small amount of area, you could potentially miss that pathology, which is very uncommon, but it can happen. And, you know, the only potential pathology that would be that small sometimes is like a metastatic brain cancer, where they're just a very small lesion that could potentially grow into a bigger lesion as that cancer progresses. Or you could scan 3D, and instead of doing slices, you could do a slab. So I know you guys have probably seen that on your scanner, where you go from a 2D to a 3D, and it gives you the option of slab instead of slice. That's what it means. We're exciting a whole area. So instead of, in this example, slices 1 through 6, we just basically excite an entire slab. So those are some remedies for cross-excitation. So once again, don't get crosstalk and cross-excitation confused. All right. The next artifact, the pressure's off us a little bit because it's really not our fault or the patient's fault. It's the engineer's fault, or just how the room is designed. So the next artifact is called Zipper Artifact, and you can see why it's given that name. Just look at this artifact streaking across the image here. It has this kind of zipper look to it, like in your pants or on a coat. And this is caused by extraneous RF entering the room at a frequency that matches the frequency of the expected echo. So remember, we're collecting echoes, and usually, we're collecting echoes around the precessional frequency of certain tissues. So there are other RF bandwidths that are potentially going to be processing at that same frequency. And those are things like a broadcast radio. Imagine if you had a radio station right next door. That can accidentally get into your room. Wireless computer network, so Bluetooth, things like that. For some reason, if they're kind of linked or hooked up into that room, or if a patient brings in a Bluetooth set and then you guys tell them to just lay it on the counter within the zone 4, it's far enough away from the scanner, it's not going to cause any projectile issues, but you just tell them to lay it down on the table next to it. That can cause interference. And even sometimes a light bulb that is not MRI compatible, or it has burnt out. Sometimes with that, the filament with it being broken can cause this extraneous RF entering the room. So it's really important that you guys check and make sure that Faraday cage is as enclosed as possible. So a lot of the technologists really check those copper teeth that surround the door. And remember, when you guys enter an MR room, you always probably go, man, why is it so hard to get into this door? It's a heavy door. It usually has like a little suction to it. The reason is because we have these copper teeth surrounding the entire door that is preventing this extraneous RF from entering the room. So if you have a breach in the RF cage by one of the copper teeth broken off, it can create this extraneous RF from getting in the room. So think if you have like a patient come down from the floor and you switch them over to a MRI safe or MRI conditional EKG leads, but at the same time you didn't bring the EKG leads from the floor into the room, but you just left them on and they're sitting on their bed in zone 3. If you have a breach within that Faraday cage, that monitor could produce an RF band that could accidentally leak into the room and cause this artifact. So this artifact's going to occur in the frequency direction, and it's going to look like a high intensity line at a specific point streaking across the image, because that's where it matches the precessional frequency. Okay, so remedies, we need to call the engineer. Sometimes we can't locate this extraneous RF energy from coming into the room. We've looked everywhere. We've turned off all the monitors in the department. We've checked all the light bulbs. We've seen if there's a random Bluetooth. We checked the Faraday cage and we still can't locate it. That's when you need to call the engineer. A simple solution is if you see a broken tooth, make sure you get that repaired. Always close the magnet door when you're scanning. So I know a lot of your technologists, when you're scanning, they go, hey, can I enter your room? And I know Deborah does this all the time. She says, can I enter your room? And you say, yeah, that's fine, because she's prepping for the next exam. The only issue with that sometimes is that you can create this artifact, because the minute that door opens while you're scanning, that extraneous RF energy can enter the room. So if you scan while they entered the room and this artifact shows up, just make sure the next time you scan, repeat that scan and make sure nobody enters the room at that time. So I put common causes. Typically, they're light fixtures not rated for MRI, Bluetooth devices within the MR suite, because we know a lot of things are going Bluetooth. So even your Apple AirPods, if they keep them just like, because I see some facilities, they allow these patients to bring like their glasses and like AirPods into the room, and then they have like a little cabinet for them. Those can cause these extraneous RF pulses. Who here has a technologist that constantly likes to go in the room while you're scanning? Tisha. Anybody else? Good. I think it's good that you don't really, that's kind of not the best practice to kind of constantly go in and out of the room while you're scanning. But I understand if it's a really busy facility and you have to kind of prep the next patient. But maybe moving some of that prep stuff into a different area so you don't have to constantly go into the room would be a good idea. All right, the next artifact is called shading or dielectric. Okay. So we get dielectric because we're inducing a current, basically. So we're caused by local eddy currents due to increased conductivity of body tissue. So certain tissues within our body are more conductive. So what do you think would be a more conductive tissue in your body? Let's say muscle or fat. What do you think? More conductive?
Muscle?
Muscle, yeah. So remember, when you're working out, you're firing those neurons and different things like that. Those are very highly conductive tissues. So that's where electricity can flow along easily. Fat is more of like an insulator. So it kind of, insulates that if there is any electrical charge, it's not going to move. It's going to impede an electrical charge. So fat, typically, if an electrical charge comes, up against fat, it's just going to stop, and that's where it can cause burning sometimes. So if you're scanning an area that is more conductive, like muscle, you might get more of these artifacts. So these artifacts look like area of shading or signal loss. This can also be caused by abnormal loading on the coil or by coupling the coil at one point. So let's say a large patient who touches one side of the body coil and couples it at that point. But then on the other side, like if you have a flex coil on the top of the patient and behind, say you didn't center that flex coil up appropriately and it's kind of pushed off to the one side. So the back and the front are touching on this side, but then they're not touching on this side. So there's a gap. That's what it means by coupling. So that can cause this shading artifact. And then it can also be caused by uneven excitation of nuclei within the patient due to RF excitation pulses applied at flip angles other than 90 and 180. And 90 and 180 are great because usually we flip those nuclei right into that transverse plane, which is where we collect the signal. And 180, usually that's good too, because that completely refocuses our spins and allows our signal to regrow. But if you use other flip angles, sometimes it's not always flipping it exactly 45 as they say. Those hydrogen spins, sometimes, one might go 45, but then 4 of them might go 43, or 4 of them might go 57. So there's some variation when you use a flip angle that is not 90 or 180. And that can cause this shading or dielectric artifact. So this occurs in both the phase and frequency direction. So you kind of see it throughout the image all around. And it's basically difference in signal intensity across the imaging volume. So look at this image here. So it's very bright where the coil is kind of touching on the patient's abdomen and also kind of where the coil is at the back of the patient. But then it gets darker for some reason as you kind of traverse through the middle of the patient. And it's darker on the edges out here. So this is called shading or dielectric artifact, where it just looks darker at certain points. It's like uneven, like it's dark on one side, it's bright on the other, it's dark in the middle, it's bright on the edges. So it's an uneven shading or uneven contrast. So some remedies to this. Make sure you use the right size coil. So, if you're scanning the knee, don't use an abdomen coil. Make sure you use a flex coil or a dedicated knee coil. Use foam pads so that the coil's not directly touching the patient. You want it close, but not directly touching the patient. Make sure the coil's not directly touching the bore of the magnet. Use pads there too. Make sure that there's no coupling where one side's touching and then there's a gap on the other side. So those are some ways that we can load the coil correctly. Make sure they're plugged in correctly. I know that's sometimes an issue where you set everything up perfectly, but then you don't really push that coil into the table appropriately. So make sure it's plugged in appropriately. And so here are some examples of ways that coil can be loaded on a patient that causes this artifact. So look, even if you just have one coil on top, if you have a patient with, like, let's say a big chest, barrel chest, it could cause the coil to kind of be further away at one spot and closer at another spot. So that's an issue. So you want the coil to be nice and parallel with the body part. We know that we typically sometimes have to use 2 abdomen coils if we're doing like an abdomen pelvis. So if you've been in a hospital or a clinical site where you have to do the abdomen and then move down to the pelvis, typically we have 2 abdomen coils to cover from the top of the liver all the way down to the pubic symphysis. It's important that we do not basically overlap these coils so one's a little bit higher than the other. Let's put these coils right next to each other. You know, don't have them touch, be very close, but, you know, leave a small little gap, but not so that, you know, one is over top of the other like that, because that's going to cause this shading or dielectric artifact. And then it's really important that we shim. So, you know, you can locally shim with your shim coil on a GE and a Siemens scanner, but you want to make sure that the system automatically shims before every pulse sequence. So when you see that in the bottom left corner on a Siemens scanner, it says magnet is shimming, let it do its job, because that's going to make the field as homogeneous as possible. And when we get a homogeneous field, we'll get less of this artifact where we get variation in the image contrast. Okay. All right, next artifact is called Moire. It's like a French word, or also called zebra. And you'll see why it's called zebra. I like to refer to it more zebra just because of its appearance. So this is a combination of 2 of the artifacts we've already talked about. So we have a combination of wrap, so aliasing or phase wrap, and field inhomogeneity, especially when we're using a gradient echo sequence. Because we know that those 180-degree refocusing pulses in a spin echo typically correct for this field inhomogeneity, but the gradient echo pulse sequences don't have the luxury of those 180 pulses. The gradients actually rephase the spins. So it's not as efficient as getting rid of this inhomogeneity. So the inhomogeneities cause this wrap to be in and out of phase with each other and cause this banding artifact. So we talked about the 2 artifacts up here, in and out of phase. Here, in and out of phase. So we get, you know, where it goes in phase, out of phase, in phase. So in phase is typically high signal, out of phase, dark signal, in phase, high signal. So that's what's going on here with the appearance of it. So you can say in phase, out of phase, in phase, out of phase. That's where you get the zebra appearance, because it makes it look like stripes on a zebra. And we know that the field is most homogeneous at isocenter. So here we put isocenter right in the middle of the abdomen. So we don't see these artifacts kind of in the middle of the image. We always see them on the edges of the field of view, because that's where our precessional frequencies are going to have the most variation from isocenter. Because remember, we turn on those gradients and they go from linear to a more sloped appearance. And so at isocenter, it stays the same, but then now on the edges, our precessional frequencies have changed the most. So you're going to see them on the edges. So then let's talk about the other artifact that it's incorporating is our phase wrap. So that's why it kind of looks like this, because just like before, if you have a field of view that is too small, the anatomy that is outside is going to wrap into our image. So it's actually this anatomy that's wrapping in is the arms that are basically laying right beside the body. So it creates this in and out of phase wrap that occurs on the edges of the field of view. That's where we get zebra or moire artifacts. So this is kind of a combination of two artifacts. And this is always seen with gradient echoes, because once again, gradient echoes lack the 180-degree refocusing pulse. So you'll typically see these with these abdomen scans that are usually just like localizers, or usually you're trying to just see the anatomy to kind of see where the top of the liver lies so that you can set up your axial slices. So sometimes even if you have the artifact, you don't necessarily have to repeat the image because you're able to see where that liver lies, and then the other scans are really going to be the ones that the radiologists really look at to determine if there's any pathology. All right. This patient, it looks like they have kind of an enlarged spleen. I don't know if you guys see that already. Like if you guys just kind of quickly, this is just a localizing scan, but you can see that this is the liver. And this side, it looks like there's another liver, but we know that there's no liver on the left side of the patient. So this is probably their spleen that's enlarged. So that could be causing a lot of issues. And see how it pushes up the diaphragm on the left side, which no left side, the diaphragm normally sits lower. Just to kind of keep your eye on pathology. So remedies, instead of a gradient echo, let's use a spin echo, because we have our 90 and 180. Even better, a turbo spin echo, because we have multiple 180 refocusing pulses. But we like to use our gradient echoes for these localizing scans because they're fast, right? And you can tell the patient, all right, hold your breath for 5 seconds. I'm just going to scan, get a localizing scan. So sometimes it's really not, that bad of an issue to have these artifacts if it's really just a localizing scan. You could say keep the patient's arm within the field of view. So if you can make the field of view larger, you can add oversampling. Or make sure you really shim the coils and shim the magnet before you scan, or shim the area under the field of view. So some ways to reduce or eliminate that artifact. All right, next one. This one's called magic angle. So I have yet to see this artifact in clinical, but I would be surprised if you happen to kind of come across this, because I just think it would just be terrible luck, and I'll describe why that would be. Because this basically means that you have selected a TE time and have the patient at a very specific angle within the scanner that creates this artifact. So this, by definition, is caused by T2 decay time increases when collagen-containing structures lie at 55-degree angle to B sub 0. So that is very specific. So if you just happen to position the patient's knee or shoulder at a 55-degree angle from B sub 0, and remember B sub 0 is running straight down the bore of the magnet, and we selected a very specific TE. So what happens is this occurs in both the phase and frequency direction. And it appears, this is seen in tissues that contain collagen. So typically like the tendons. So you can see here, this is the patella tendon. We have the quadricep tendon here. We have the rotator cuff tendons kind of converging here. So when this is going to be an increase in signal intensity when a short TE is used and the anatomy is lying at 55 degrees angle to B sub 0. So here you can see that we have a signal intensity increase in the patella tendon here because it's at 55 degrees from B sub 0. Here we get a little bit of signal increase in the anterior cruciating ligament because it's at 55 degrees. Here you can see that signal intensity kind of increasing right behind the patella. Here you have a signal increase right here in the rotator cuff kind of area where all the tendons converge. Remember the 4 tendons that converge to make up the rotator cuff? Here again, you have a stir image, but then we get an increase in signal intensity in this patella tendon just because it's lying 55-degree angle from B sub 0, and we use a short TE. So once again, this is just like a very rare occurrence type artifact. But if you do see this increase in intensity in like a tendon where you wouldn't think, like their patient's not having any pain down here, maybe just rearrange the patient or change your TE slightly and see if that artifact still persists. So the remedies are really just change your TE slightly. So instead of using a very short TE, let's maybe bump up our TE a little bit longer. Our tissues are going to have more time to decay, but might not be that artifact anymore. Or alter the position of the anatomy. So just go in there and change the anatomy just slightly a little bit, just so that it's not at a 55-degree angle. So once again, very rare that I haven't seen it in clinical, but it might happen in your lifetime as a technologist. So just be aware of it. But this is magic angle, and they call it magic angle because it happens at this 55-degree angle to B sub 0.
And this is when the patient is angled in the scanner?
Yeah, I mean, it's just their anatomy's angled in the scanner, 55. The knee, it seems odd just because typically they're in a knee coil that's kind of running perpendicular. But sometimes you have to put them in like a flex knee coil and have them kind of in a weird position. So that can cause that artifact. It more commonly occurs here like in the shoulder where you have them in a shoulder coil and then they're kind of at a weird angle. And then that angle's 55 degrees to B sub 0. So I would say it probably more occurs like something like this than in the knee. But if it is the knee, maybe it's just because you didn't use a dedicated knee coil. You use like a flex coil or something. Good question, though. All right, moving right along. Next one is called partial volume artifact. So I'm going to do some drawing here. Okay, so this occurs when many different tissues are averaged into one voxel. So let's draw a little bit. Let's do a little rectangle here. So imagine this is our voxel. I say voxel, but we know that a two-dimensional voxel is a pixel. So let's just imagine this is two-dimensional. This is a pixel. And let's say there is a small little tumor within that pixel. Let's say the tumor is about this big. Okay? So to get a certain signal intensity from this pixel, we have the tumor that's blue, and then the white area is just normal brain tissue, let's say. So basically, to get a certain signal intensity, we average all the tissues together within that pixel. So your tumor signal intensity will get averaged into the normal brain intensity, tissue intensity. So it almost kind of covers up this pathology because these tissues all get averaged together. Okay? So this happens typically when you have very large pixels because there's a lot of different tissues within that one particular pixel. But let's say if we increase our matrix so that we have now a very fine matrix. So it looks something more like this. So you can see our pixels are getting way smaller. All right. And then here in this scenario, we know that we have basically just one tissue within certain pixels. So here, this is definitely just all blue because it's just tumor. All blue here, all blue here, all blue here. all blue here, all blue here, all blue here, here. There's a little bit of white here, so that's going to get averaged. And then this is all blue here. So there's like 6 or 7 pixels that are just going to have tumor represented in that particular pixel. But then these particular pixels where we get 2 different tissues are going to get averaged. And then outside here is just going to be brain tissue out here. So we're more likely to see that tumor when we have smaller pixels. So what's happening with this partial volume artifact is our pixels are way too big, and we get what we call unsharp or blurry images because either our slice thickness is too big or our matrix is not large enough. And so that tumor might be right here, and we're not able to detect it just because our pixels are too large. Okay, because all the signal intensities within that pixel get averaged together. So it gets averaged out, you could say. So remedy for this one would be to reduce slice thickness. So go from like a 5 millimeter down to like a 3 millimeter, or reduce our voxel size. So we increase our matrix. So go from like a 128 times 256 to a 512 times 512. But we know that there's issues with that. So if we increase our matrix, typically our signal intensity goes down a little bit. So you might have to, bump up your next, which increases your scan time. So there's all these parameters issues when you start adjusting for your resolution and your signal. And we talked about that in chapter 4 when we covered parameters. But this particular artifact is just basically caused by the pixels being too large. And you're going to see this in the slice direction. So on each slice, you'll see this blurry, unsharp image. All right. So moving right along, we're doing good. Next one is called field distortion or sharkbite. So a lot of people call this a shark bite in the MRI field just because of its appearance. Look at these little, indentations that look like a shark bite on the edges of the field. So this is caused by imperfection in the homogeneity of the static magnetic field. So the static magnetic field is not very homogeneous, meaning it's not 3 Tesla all the way along the length of the bore. And we know that's very hard, especially with very large magnets. So typically at isocenter, we have the best homogeneity, but then as we go out from isocenter, we start to lose that field homogeneity. So when the static magnetic field is not uniform, fat and water may not resonate at the frequencies that we have predicted. So remember, we say on a 1.5, typically they're 220 hertz apart. But when we get towards the edges of the field of view, our homogeneity is a little off. So, fat and water might process at a little variation from the 220 difference that we normally predict. So this will represent patient anatomy incorrectly. So this is going to occur in the slice direction. So you're just going to see this on every slice going through your stack. So here, like I said, we have the best homogeneity at isocenter. So areas near isocenter, so at the middle of your field of view, will be more uniform in field strength than at the periphery of our patient. This means that the imperfections of field inhomogeneity found at the edges of the field of view will be in the periphery, and this is where you'll find that artifact. So you'll find this Sharkbite artifact along the edges. So the reason for this is because we selected a field of view that was too big. So maybe we need to choose a smaller field of view so that our field homogeneity is more consistent along the entire field of view. And then let's just try and avoid gradient echo sequences, because once again, we don't have that 180-degree refocusing pulse that corrects for field inhomogeneity. And typically we see these shark bites, they're more pronounced when we use a fat sat technique. So here, this is a fat sat image of the pelvis, soft tissue pelvis. And remember, if fat and water are not at those predicted values, we're going to get this artifact where it looks bright instead of dark. So we're starting to, like what we say, lose our fat suppression along the edges of the image. Okay.
So is this the artifact where you see when the little box pops up about the, I don't know what it's called, like when water and fat is.
Yeah, that's perfect. Markavia. That's so those peaks are that like if you're working at the 1.5 Tesla, they're 220 hertz apart. So typically you want to move that RF pulse above the fat peak, which is usually the smaller of the two peaks because there's usually more water than fat within the patient. And that way you suppress fat to the best of ability of the scanner. And that usually works out very well, but once again, it usually works out best when you're at isocenter. But as you go out towards the edge of the scanner, remember, we're turning on these gradients. So at isocenter, even when we turn on a gradient, isocenter stays the same precessional frequency. So look at how my two fingers connect. This is isocenter. When we turn on a gradient, it causes this slope where we have more positive in and more negative in. But isocenter stays at the same precessional frequency, but at the edges, our precessional frequencies change a little bit. And it's hard for our system to kind of predict where that RF pulse should be applied. So very good. But that's, anytime you do a fat sat sequence, that little prompt, and that's just dependent on how the scanner's set up, usually pops up. And it's just basically, is this kind of where you want the peak to be over fat? And usually the tech just clicks continue. Okay. Sometimes if the fat set doesn't work, they have to manually go in there and adjust the peak. You'll see that where they kind of find water and then add 220 to kind of get right on that fat peak. But yes, that's exactly what's going on. All right. And then the last artifact. This one is called Herringbone. I've also seen it called like tweed or like variations of, certain like fabrics. Corduroy, you'll sometimes see it appeared as. But once again, this is really not really our issue. Something's kind of going on with the scanner. So this is caused by malfunctioning of coils or other equipment within the scanner. This is caused by spikes in noise caused by external forces. These may be equipment in the MR scan room. So there might be some extraneous RF, but that's really more for zipper artifact. But let's just say some of the equipment's not functioning appropriate. It could be causing this artifact. It's also sometimes caused by when you are converting our image in K-space into our actual image. So there's an issue with the fast Fourier transformation. Because remember, we collect all this data. All this data goes into K-space first. Remember, we fill every row of K-space. But K-space is not our image. We have to put it through the fast Fourier transformation, kind of like an X-ray, and then an image appears. So there could be an issue with that fast Fourier transformation. So, the K-space and the image, something happened, there was a miscommunication between the two. This occurs in our slice direction. So on each slice within the stack, you might get this weird fabric type of appearance or herringbone appearance. So once again, this is caused by spikes in noise. So noise can be created by the scanner, the environment, and the patient. So if there's just some extraneous noise within the patient, maybe maybe you're scanning the abdomen, but then there's a big shoulder replacement that might cause a spike in noise for some reason. They could cause this artifact. So it's represented by multiple black and white line patterns across our image, kind of like this cross stitching looking thing. So our remedy, check the equipment, repeat the sequence. Sometimes an artifact like this will appear, and if you just repeat it once, it might disappear. And it's just one of those random things that happen to you. So I recommend if you see this herringbone artifact, just repeat the sequence. And then if it still doesn't go away, you're going to have to call your engineer or your physicist, see if they can fix it. All right. So that's the last artifact on the chart, but I wanted to make sure I show you different variations of these artifacts. So let's see. We got to Crosstalk. Okay, so I don't have another image of Crosstalk, but here's another example of cross-excitation. So remember, cross-excitation is where these slices, this is the true slice profile. Remember, they're more rounded. They overlap because there's no gap between the slices, and this causes saturation where these slices converge. And this will screw up your image contrast. And just look, on this T1, you're not really able to see the difference between the white and gray matter. The CSF fluid is not as dark as it normally is. And then just look at how you go through the slices. One's a little lighter, then one's darker. One's a little lighter, then one's darker. So that's how you can tell if you have this cross-excitation artifact. This image I already showed you before, and just look at how just low contrast of an image this is, and then higher contrast, where we're able to see the white and gray matter easier. That CSF fluid is nice and bright. Oh, here is an example of crosstalk. So here, that band is going right posterior to the spinal canal. Here, I would say that you might have to repeat this one because it's getting a little too close for comfort for me, and it's getting really close to that posterior spinal canal. It's really covering up that spinous process. I would go ahead and repeat that sequence. This one for sure, look at it, that band, that crosstalk band is going right through the spinal canal. And this is what's causing it. You can see it here, the overlapping of the slices. Is there a remedy for this one?
No.
No, you just have to be mindful of how you set up the slices. There's no remedy. All right, here's a zipper artifact. So random RF, extraneous RF is entering the room. And remember, sources for that is like if you work next to a radio station, or if you have Bluetooth or a monitor on in zone 3 and it's getting into zone 4, or you have just a random monitor on in the room. It could be a light bulb that's not MRI compliant, or a light bulb that's burnt out. All these things can cause zipper artifact, and they typically occur in the frequency direction. So if you're trying to confirm if this is an RF leak, you could just run the scan again and flip your phase and frequency direction. And if it goes from here to here, you know it's an RF zipper artifact. And I need to figure out where it's coming from. So here's that artifact. So which direction is the frequency direction? Is it head to foot, or is it right to left?
Head to foot.
Which way is the artifact traversing the image?
Is it the right to left?
Oh,
It'd be right to left, right to left. So your frequency direction is going to be right to left. Your phase direction is going to be head to foot. Because remember, this artifact streaks across the image in the frequency direction. All right, let's try this again. So then here's the artifact going across the eyeballs. So which way is our frequency direction? Right to left or A to P?
Right to left.
Good, right to left. All right, next one, we talked about shading. And just look at how the posterior part of the patient here for the C-spine axial is brighter than the anterior part of the C-spine. This could be caused by just not having the anterior C-spine coil on, or just it's not appropriately placed on the patient. So you look at how it's darker here than it is back here. Another example, I might have to blow this one up, of shading. You can see that it's a little darker on the right side of the patient over here compared to over here. And that could be caused by that coupling of the coil. Remember, where one side of the coil is touching, the other side has a gap between it. Here's a zebra or moire artifact where we have in and out of phase plus wrap from the arms, causing this zebra appearance along the edges of the field of view. Typically, this occurs with a gradient echo pulse sequence. Here's another look to it. I already showed you this one. And then this one right here, I labeled it wrong. Which one should this be? Not moire or zebra. What has this fabric appearance to it?
Herringbone.
Herringbone.
Nice, herringbone. Good. So this is another ways that they can appear. And these are those noise spikes caused by either the scanner, the patient, or the environment. So sometimes all you have to do is just repeat the scan and that will solve it. But sometimes you have to call the engineer. But if it looks like fabric, typically it's this herringbone artifact. Magic angle, you can see the patella tendon happened to sit at 55 degrees from B sub 0. We know B sub 0 always runs head to foot. This is B sub 0. So that particular tissue, which is cartilaginous, was at 55 degrees, and it caused an artifact to kind of appear in this area. On this one, it happened to be right here instead of at the bottom of the patella tendon or at the attachment place. But B sub 0 runs head to foot. So this is where the foot is, because we know the knee, this is the femur, this is the tib fib. This is the head of the patient. And this is, let's say this is the bore of the magnet. So let's put a circle at the top. Bore of the magnet kind of looks like this. So the patient is kind of sitting in the bore of the magnet. Okay, and it's 55 degrees. So once again, it's kind of want to just reposition or change your TE slightly. Magic angle again for the rotator cuff and patella tendon. And then I just added a quick breakdown. And this is from your book, but you know, the chart that I have, I think is more in depth, but this is just from your book. So any questions? Make sure you guys print that chart out. Use the printer-friendly PowerPoint presentation. Print that out for your clinical going forward. And if you don't have no questions, I just want to play a quick Kahoot game.
I sent you some, but I sent it to you privately, but I'm having issues printing it out.
Okay.
It says that it's like a corrupt file or something, won't let me do it.
The PowerPoint presentation's corrupt. Has anybody else experienced that?
No, the not the PowerPoint, the printer friendly one. I tried it in Firefox and I tried it in Edge, but just the printer friendly, the PowerPoint was fine.
Well, try it in Google Chrome. Let me see if I can open it. Somebody else do it right now while we're here, just so that we can see if it's a web browser issue.
Where's the file located?
So go under Artifacts Unit 3, and then there's under that it's called Artifacts Chart Printer Friendly, and it's just a PowerPoint presentation basically.
Mine opened.
Okay. So try Google Chrome, Shamarva. See if that works. Because
Whoever that opened, what were they using? Safari, Google Chrome?
I'm using Chrome.
there shouldn't be any corruptness about it because it's just a PowerPoint presentation. Hopefully it's not. But if you still have that issue, let me know. All right. And what you can do there is just print, one page per document, and it should come up. So I just did it earlier today just to make sure, and it comes up nice and neat. All right. So while you guys possibly print those things out. We're going to go over here to Kahoot and play Name That Artifact.
Google Chrome worked.
Nice.
Thank you.
Halloween theme. All right, I think we got everybody here. Pumpkin. Yeah, Shamarva. Awesome job. Curly hair.
Me.
Um,
I had it earlier.
oh, no, you're great.
Fabulous, Shane.
Hey, wow.
So I really want you guys to, I think with those, you might have known the artifact, but you don't remember the other names for the artifact, like the other name it's associated with. So make sure you, because that's going to how the registry is going to be. That's how my test is going to be. Like make sure you know phase mismapping is also ghosting. It's also motion artifact, because like with that sagittal C-spline where it was streaking across the image, if I put the option of motion, you might have got it more, better percentage of people getting that right. But if I just put phase mismapping, you're like, wait, what does that mean? So make sure you know all the different names for each artifact. Make sure you know the appearance. So go over every image that I put in this PowerPoint, but also on the just artifacts PowerPoint. So you know the appearances of these artifacts. Make sure you know the axis or the axes that these streak across. Okay, so you will need to know that for sure. And then obviously the remedies is a big factor too. So your best friend is this chart. Study it, know it like the back of your hand, because this will not only help you for the test, but this is finally really something that you can apply in clinic. Okay, so I want you guys to be excellent MRI techs going forward, and this is our first step towards that, along with our parameters section.
The Kahoot will be up as well as the video of this class today.
Kahoot, you won't have X, but the video of today will be up. Yes,
Can we play it again?
let's see if I can provide a link. I don't know if you can play it again because it's just, let's see.
It's just I'm kind of out of it today from being sick, and I'd like to play again. I didn't do bad, but I like to play when I feel a little better.
So here's the link. I can copy it, and I will email you guys that link. How about that?
That's great.
Thanks, Sean.
You guys have a wonderful, well, actually, we have procedures, but it's actually just a quick class. So we'll reconvene here at, let's say, 10:10, and it will only be like a 15-minute lecture because we're almost done with the PowerPoint. And then you'll have a little bit of an extended lunch today, which would be nice. So I will send the Kahoot link. I will have hopefully the YouTube's posted by tonight. And I will see you guys in 10 minutes.
Thank you.
Alrighty.
Hey, so Sean, can I hold you for a sec?
Sure. Let me, and